Again, this is a session that will be recorded, so if we can share any information with our audience, I really do want audience participation, and I'll get to that in a minute. Let me just tell you that this month we're looking at, the whole topic for the month of August is expanding and enhancing the research capabilities in the office, beyond your clinical research office itself. So today we're going to talk about how do you engage clinical personnel in your research. That sometimes is quite a challenge. So we're going to talk about, I'll go over some slides, and then I have a few folks who we've put in the audience who are going to share how they manage dealing with the clinical staff. And then if anybody else has anything to contribute, we really encourage you to do that. Next, in a week from today at 12:30, we are expecting to have what we call kind of team building program. Anthony Hood is going to be here, and it should be a fun, just interactive session, but on how to strengthen your office infrastructure, just how to strengthen the internal communications, but he has a lot of great slides as well as a lot of interactive activities so that you get to experience a bit of team building in this group. The third session for the month is working with outside research groups. So if you're running a multi-center study, how do you deal with people that you have to oversee or manage who aren't at UAB or aren't in your office? And they're also research personnel, whereas today we're going to talk about clinical personnel. So that's what our month looks like. We still have the fourth, just a reminder, the research orientation program is the fourth Thursday. If you know anyone who's interested, please contact Darby and get them registered. This will be our fifth month doing it, and we've had a really nice turnout each month, and I think the program is getting better each month. So I am going to start today. So Cindy's not here. I think she's in the midst of selling a house and building a house, so she needed some time to deal with those issues. And so I will just be presenting a series of about 20 slides. I don't even think it's that many. Just to give you an overview, a brief discussion, a few pointers on dealing with things to consider when dealing with research staff. So, as any project we ever undertake, working collaboratively is always going to provide a more successful outcome than if you try to work and do everything yourself. Now, there are many of us in this audience who I believe who are really willing to do it all themselves, only because they work so hard. But there's a point where we need to depend on other people. And that's so true with research. Being able to engage and bring into the fold the clinical staff, whatever way we can. There just are great benefits for doing that. Team members depend on the study design and complexity in the facility. So again, as a team member, you have to really understand who are your research clinicians, who are the clinicians and the clinical staff you will be dealing with. It'll help you get your brain around how you're going to include them in the whole team effort. Certainly multiple departments. It isn't just like the nurses in the clinic or the nurses in the staff. I mean, this whole concept of engaging the clinical staff, it extends beyond that, ophthalmology, radiology, and all the other services that you might include in your protocol. The benefits is, as you all know, these are probably things that are not unfamiliar to you, but effective teams lead to improved patient care and outcomes, improved data collection, increased recruitment and retention, reduced errors and delays, and improved subject-informed consent. If you were just as some examples, if you were to think about let's say you have a patient who's going to be in the hospital, and although they're going to be cared for clinically by the nurses on the floor, you're going to be there you're coming in and out doing research activities. By engaging them in the concept of the subject is on research, you're going to get they'll be more engaged in providing you with the data you need. Maybe they need to be recording overnight certain data that will help you address your outcomes. They'll be more engaged if they understand you're doing research, and they understand what research is, but we'll come back to all of that. Again, so that's associated also with improved data collection. Increased recruitment and retention. I think if you have a subject who's coming into clinic and they're coming also for standard of care, if the clinic nurses have an idea, have an understanding that the subject is also in research, they won't finish their clinic visit and just send them home. You know, they'll be aware of the fact that they have to hang around and meet with you. Again, it's making them a part of the team in whatever way you can will help them stay focused on that concept. Reduced errors and delays. If you are depending on, we have one study where we're going to have to draw PKs during the night, and they're going to be hospitalized in the ICU.
Muted. Unmuted.
Engaging them in the study, as well as being there during the night to work with them to say, okay, within the next 10 minutes, can you draw a PK for me? Because again, many times subjects in the ICU, I'm the nurse or the patient's nurse. I wouldn't want anybody else touching my patient. So again, it's working with them, engaging them. Improved subject-informed consent. If you can, educating the staff on what the subject is on a research study, and maybe helping them understand the clinic staff, helping them understand what the study's about. If they're interacting with the patient, they'll, be able to be part of the informed consent process. At least they hopefully won't say the wrong things and won't speak negatively about the research. I think that's maybe the biggest concern you have if you don't educate them. As always, we have the issue with clinical care versus clinical research. These two bullets are really not anything you all don't know, clinical care. But I think one of the reason for this slide is really to say this is how we can use this sort of information to share it with the clinic staff. To say, okay, so I've got to, I sometimes think clinic staff, they're so busy with what they do, they don't think about research, and they don't understand why we do what we do. Helping them understand the difference between the two is an important concept, as well as teaching patients what the difference is and understanding it yourselves. So, clinical care is really just an interactive activity between the patient and the clinical staff, whether it's the doctor or the nurse. Clinical research is really an activity between a researcher and the public. And that subject is part of the public, and they can't make a decision. In this scenario, in the clinical care one, they have an opportunity, the patient has an opportunity to determine their care many times based on interactions with the clinic staff. In clinical research, that is not the case. It's cookie cutter. If it's research, you've got to do it the same way every time, and it's no longer a private decision, but the data becomes public, not the subject himself. Challenges that we face with the clinical staff. There are many challenges, and this is probably just a few of them. Again, as I said earlier, sometimes they lack knowledge and understanding of what research really is. And so you, as a researcher, come in and you're in their way. You just cause them more problems than you're worth. And that can hinder your ability to get the assessments you need, to get the data you need. And it can hurt the subjects too, because they can pick up on those conversations and then, why am I in this research study if the nurse thinks it's a bad thing? The clinic staff have limited time. They're all busy. We're all busy, and they have requirements that they have to do, and they have as much paperwork as we researchers do. And so they need to keep, again, they're limited time, and so asking them to do extra things is rather challenging. Again, insufficient support. Again, that's kind of how we operate these days. None of us have enough support, but the clinic staff has to address that as well. And again, unclear goals of the research project. So the clinic staff, they don't understand why you're doing what you're doing. They don't understand why you're drawing blood every hour for 6 hours, and it can make it very difficult for them to comply. Can anyone think of any other reasons why the clinic staff, what other challenges they might face? Anything on this too? So some of the basic solutions, 99% of the time communications will solve everything. That's why we put this as the number one solution. sharing with the staff who, why, what the research is all about. Again, that engages them in the process. That brings them to a point where they can feel part of the team. You know, we have a couple of studies that I've recently been involved in where there's been questions from the patients of why do I have to be in research? Why can't I just get the drug? And I think, in thinking about that as I was walking over here, I think what happens for research staff, our clinic staff, is that they have a tendency to forget that the drugs they're giving today all came from research. That if we don't study them, they're never approved by the FDA and they're never available for use by the clinic staff. And it's, you know, yes, it may add to the complexity of caring for a patient, but it's all for reasons that will help them in their clinical care. You know, the phrase evidence-based medicine has grown in the past 5 years. I mean, when I was in school, that wasn't used, but that's, you know, that is what it's the evidence-based medicine based on our research that improves practice and causes practice. So it's, again, sometimes we have to be reminded of why we do what we do and why we're able to do what we do. I think when you're just in the clinic, or when you're a clinic nurse, you don't think about those things because you have other things that are on your mind. Where we are just, you know, that's at the top of our brain. Why are we doing what we're doing? It's to improve clinical care. If you have an opportunity to include staff in research meetings or updates, that's a wonderful thing to do. Many times I'm sure they can't leave the floor for meetings, but if you have one unit that you're working with and you have one study that they've been heavily involved in, you know, through the course of the study, you could let them know how you're doing, how you're, you know, we often, in research, often think competitively at times when we have multi-center studies, and if we have a study where we are maybe #1 in the country, you know, sharing that with them to say, hey, look, we are doing better than all these other institutions. You know, we all have a bit of competitiveness in it, but the staff are involved in that too. Anything that's positive that you can share with the clinic staff about the research may help engage them as well. And that kind of goes with sharing the results. We're doing one of our novel studies is people with microbiome transplant, and the results are phenomenal. But it's a research study, and the patients are often in the hospital. But you know, the staff begin to see that this is making a major difference in the subjects, and being able to share with the staff, you know, what they're really seeing, you know, what's happening, because they may not understand what's actually happening. But again, sharing the results so they can see that they're part of it. They're part of improving healthcare. Relationships, again, kind of goes with communications, but you know, there's nothing that engages people in being part of your research and building a relationship. You know, get to know the nurses, get to know the staff, partner with, you know, just be aware of and build the relationships with all the possible entities that you might be using in a research or need to use in a research study. We all could probably share some issues related to that. And keep up with those relationships. And the other part is cookies are always a good idea. I had somebody help the other day, was really getting a research study started, and I decided to buy them. Is that coercion? I don't think so. It's after the fact, you know. It's
okay, that even take cookies, just a simple thank you. Or just, you know, hey, yes, this patient was completed, thank you for getting that blood because I wasn't being compliant. It's just simple.
That's great. I think you're right. Just even a simple thank you, because it doesn't happen this. I mean, in general, we tend to, everybody's so busy, we just keep right on going. But to take the time to really thank them when you've been successful. And if they've been challenged by an issue that you've given to them, you know, thanking them for the effort. You know, I think that's anything you can do to keep a positive slant on all of them.
The cookies too long.
Chocolate. Chocolate cookies. Okay, #1. Education. You know, we have yet to do this here at UAB, but as we build all of our education programs for the university, for research, I would love to have a roadshow we could take around and provide CEUs for nurses in the hospital. And again, it would be We make it scientifically based so that everybody would be happy about it, but it would be educating the clinic staff about what research is. Just a 45-minute presentation where we could sit down and say, okay, we're just going to talk to you in general about research. And they get CEUs and pay, and we get a few more converts to supporting and believing in research. So the goals, the clinic providers, staff, and clinical research investigator staff want what's best for the patient. We all want to see things. And that's what's real important. We've been working with hospital administration. A lot of times within the hospital, in the administration, they don't understand research. They don't understand why we need money to support the infrastructure of the CTO. They don't understand why we need money to support OSP or all the other things we do. In the very end, even if you're just a dollar person, if you're just looking at the dollars, the truth is if we do research well and we make UAB or any institution a good place to come and for research, people will come. We will get more patients. We will increase the revenue at the hospital if we do our work well too. So, there are many reasons for doing research, and everybody on campus has a different slant, a different impression of whether we're worth it or whether we're not. But anyhow, that's something we've had to bring to the attention of some folks that this really will improve the bottom line for UAB. We do it well. Communicating and working as a team in order to provide the patient with all the information he or she needs to make an informed decision. That's our responsibility as researchers, but we want the clinic staff to also be aware of what we're doing so they can support our research. So let's go back a minute, because I just kind of skimmed through these. So in this group, do you all have any communications issues, ways of communicating with the clinic staff, hospital staff? Any experiences that you could share on how you've built those relationships, how you've built the infrastructure to engage and to bring on board? Or challenges?
I have just it's more of a question type thing about communication. I know I've seen other areas where people can put documentation in him having the patient on a particular study, and that will help me not waste a certain time that, in order to talk with maybe another person, this person is already on the research.
Right.
So how do you do that? Because I've tried to look, and I don't know if it's okay to just put it on a sticky note so other people.
Let me tell you, so I'll tell you one thing that is happening. So the question is, if you're screening for patients, and correct me if I'm wrong, in the hospital, how can we identify whether people are already in a research study?
Or even with my patients that I put on the research study.
How can other people identify?
Right.
One of the things that UAB has bought right now, and it's being implemented, it's not put together, it's called Power Trials, and it is sort of I call it, again, it's a layover for the medical record. So it's kind of like the front page to the medical record, or it will be. Within Power Trials, it will be identified, because it's used for a number of things, but you can identify, there'll be a flag that says on a research study. And you can find out contact information if you want to find someone find the person who's doing the study. But in a way, that is kind of what you're looking for, is a way when you look at a subject, how do I know if they are or are not on a research study, whether it's mine for my own, whether I can screen them, or whether someone else needs to know they're on a research study for safety reasons. And that's the whole point of Power Trials. So the other part of that is, I would say legally, it's okay to do that. So putting a flag or a sticky to show, I don't know what the records are that you're using right now, but it is okay to document that a subject is in a research study on their record. There's nothing that prevents us from doing that. Now, I say that there may be some studies where we won't post it that way. HIV, there are certain trials that may meet an exception for being posted publicly that they're on a research study. And it's interesting because even, again, you then get into the discussion about, well, If I'm an employee at UAB and it's noted in my record that I'm on a research study and that maybe in that research study has to do with HIV, again, would my colleagues know that? Again, there are some squirrely issues even with making it public. Does that make sense? With public within UAB, but I'm not going to go there because that's a whole other discussion that probably would take place on an individual basis. But in the general way, Power Trials is meant to share information about whether subjects are on research for safety and for recruitment. Hopefully it'll be in place in the next few months. We are at UAB.
I've had an issue that kind of communicating another coordinator. She's in a different area, and she screens patients after heart catheterizations. I screened before, so she wanted to kind of communicate.
Wow.
She wanted to see, how do I know your patient, which patient is already enrolled? And I said, well, for now, I guess we have to look at the chart to see the consent form because I don't know, and I just wanted to make sure if it was okay to stick it or sticky note or in the put in reports and documents that the patient's on the clinical study.
Does anybody,
Can you and her not develop a relationship that she's doing, you ever student first, maybe asking some people that's role I don't know the secret. Sometimes you have to be proactively making that happen, like ask for a meeting.
Well, I guess we could have a meeting, but I'm in the cat lab, but I mostly
Sometimes it's difficult.
Yeah.
And for the like some of the things you say in research, sometimes you have to make that extra effort. Because you're missing patients or something,
Well, I
you
don't.
can't put yourself on project or whatever.
No, I see them first. I get them first. So I get to
maybe
meet them
that's
later.
that's the best place to be.
I mean, that's it's stuff like that, especially the cancer center. It's just always it has to be. You have to put a little more effort being proactive to meet face to face
With everybody else.
Develop a plan. How can we do this then?
So let me just repeat that real quick. So one of the discussion in case for those who are calling in remotely did not hear, certainly there are the medical records, but maybe you need to build a communication plan with this other person who is maybe trying to enroll the same subjects you are, so you can share with them which subjects you have on or who's no longer available, whatever mechanism. So sometimes it's a hard copy, sometimes it's communication.
If your questions are on studies that involve clinical critical items, so they may be included on board or sidelined, which is not a medical report, but a clinical management system, which both of them are internet-based. There is a real quick way to search them, to search for a patient, which will tell you where the patient is used. So that's another way.
Not for the old studies, but some of the old
I
studies.
mean, prior to.
Yeah. And some of those are still going on, so every now and then you get one that is not.
And also,
but almost nothing.
and also if they didn't have any medical items, it would be. But for those that do have, that's it.
It's a billable item.
Quick way to search for them.
So we were just discussing that there are some other mechanisms at UAB to identify subjects, especially those who are people who are on research, and especially if they have billable items. So
something else I think for communication that you can help to remind the nurses and everybody that this study is still ongoing is we can share our monthly newsletters with the staff. That sometimes will also your slide might be highlighted, like we're the highest rolling site, and you can just highlight that and show them so that they know, hey, I'm a part of helping you get where you are. And also, I know the PIs can get involved, and not that they always take time to thank the staff for helping us with their studies, but if we could kind of get them to, the nurses not really know who I might be as much as they know who Dr. Smith is or Dr. Tabu. So if he could even thank them for their time in the study, I think that goes a long way too. It's great.
Okay, so the two things that were just mentioned, in case it wasn't heard, was sharing. If you're doing a pharmaceutical study, a multi-center study, you may receive a newsletter and sharing that with the clinic staff. And then also, the coordinators are pretty good at thanking. Sometimes if we can get the principal investigator or the researcher to thank the staff, That goes a long way.
Also introducing yourself, like, and telling them exactly what you're going to be doing for the length of time and learning the different shifts. Because I found, like, if you go up as a team and say, this is going to be on the night shift, or she's going to come cover the night shift, I'm going to do the day shift, and we're going to be here for the next 3 days. And making sure the staff knows who you are, so when you come up there, they're not going, who is that stranger going in my room? They know exactly what you're going to do, and you tell them, not only about the study and who the guy is, and if something happens, who to contact, but just forming that relationship up front, and then when you go back to the floor, they're like, oh, there's so-and-so, and we know exactly what they're doing. So I think that really helps. Start from the very beginning, and then constantly get to know each shift.
It's kind of like your site initiation. I mean, start a study startup. Make sure you go up and introduce yourself to the staff, the team who's going to be on the floor or in the clinic, letting them know just we're going to be doing this study. It's going to last this long. We'll have this many subjects. These are our faces. These are our names. That's a good idea. Kind of begins to build a relationship.
And I think it's important too. I know at the beginning of studies we train them, or we'll give them a protocol training, let them know what the study's about. But I think we should do booster training, kind of, along just to remind everybody if there's new staff and say there's something that they're missing for you, maybe that just extra little training can get everybody on board again. It's a good idea.
Especially if you're not up there a lot. I mean, having a booster training just to remind them, maybe 6 months into it, we still are going to have subjects coming in. As well as we mentioned, if there were new staff. Does anybody else use any other techniques for dealing with the clinic staff?
I think too, like, when patients come in, we never have time to just think clinic. Just give them a heads up that morning.
Yes.
Or go over, this is the list for today. That's just for me, because they'll call me and they'll say, so it says here now, or even before tonight, they'll say, hey, I didn't get a bulletin if I was on this patient.
Yeah, that's
I
good.
think it's just doing it daily, like you know there's a patient done it, or whether there was the OR in the hospital.
That's great.
Heads up.
So when the day of the patient visit, maybe first thing in the morning or the night before, whatever works for your schedule, contact the clinic staff or the hospital staff and say, give them a heads up. They'll be more compliant with helping you get
Or at least calling you.
Yeah, or at least call you if nothing else and say, hey, now what? That's good.
I think it's good to put yourself in their shoes and think, if I was a nurse before, what would I want the researcher to tell me? I wouldn't want, if I found out, oh, I've got a research patient, it may cause them a little anxiety, like, well, I don't know what to do. So if you're the coordinator, you can step by step, almost tell them too much information. I mean, you can't tell them too much, but more than you think they even need to know so that they're not, it doesn't have any extra stress. Like you said, they're already super busy. I think just anything you can think of that they may want, you should just be proactive and let them know.
That's very good. Yes, ma'am.
So something that I've seen, and I have done not back into the every clinic situation, but what I've seen in the past, especially to alert the investigator before they see the patient, there was one of the research nurses that went over to clinic the previous day, when all the folders had been pulled for the next day, and just made a little copy of the things that the study required for that visit. So when he was opening the folder, the study name was there, things that needed to be done. And especially if she was maybe still busy with another patient, and he immediately knew this is what we need to do here.
Yeah, providing a checklist, whether for every visit that you have with this, that the subject has, and having it, apparent to everyone, to the investigator, to the research, to the nurse on the floor, just so she could see if that, that she can see what you're going to be needing to do for today, whether she or he are involved, or whether it's just you. But I think it helps paint the picture. We all learn differently. Talking works for some of us. Having it in writing works for other of us. So I think sharing it verbally, and if you can provide any documentation, it really helps. You don't want to misstate. Anything else? Does anybody run into any major problems that they couldn't solve?
A struggle that we've had, and Gina knows about this too, is like with another department, something that is not your specialty, you definitely are relying on them to do.
Right.
For example, like maybe an echo for something, it's a very specific study protocol echo, and you wish sometimes, I wish I could just do that myself, but you can't. So when you're relying on someone else to do it, we have had it come up where it was not done appropriately for the protocol, and so there are many deviations, and it's really hard to have that person understand, even what a deviation is.
Right.
You tell them, oh, we're going to get deviation because this image wasn't performed. They don't really understand what that means. So that's something we still struggle with, is getting through to them that they have to do it a certain way. I don't know if you've ever dealt with that or have any tips on how to do that better.
We sat down, we had an echo, and they had to be certified, and getting them to be certified was a huge obstacle to overcome. And then we just sat down with the department and we said, you pick 1 to 2 people, and those were the 2 that we always scheduled our patients when they were there. And they were very passionate about the protocol and knew exactly what to do when they were doing the images. So it really worked really well. So we didn't get any deviations but we really had to communicate with them, make sure that they were going to be there and that they were okay with those appointment times, and then make sure the patient could be available. So it's a lot of communication between and making sure you can network between the 2, but it really helps. And when she had questions, having a contact person at the central unit she could call and that could answer her questions, because we really couldn't answer her questions. So it was just a lot of just finding 1 or 2, 1 primary, and then we had a backup person, and they really made a difference because we would get
It's a really good suggestions. So one of the comments, the question was, let's say you're working with, we'll say, ophthalmology, and they're having to do a special eye exam for you. Chances are they're not going to be used to doing it the way you have to do it for research because they have their clinical care standards. So again, hopefully if you have a large group of people who are possible, they could possibly do this assessment, you may focus on a couple of people who might be interested in doing that for their research and would be focused on the techniques and the methods that you are required to abide by for the research, and then scheduling your patients in such a way that they come in on the days when those folks are there. Because it's true, if you are part of a big clinic, we do audiology exams, and not everybody cares about research. They're not, and so you really want to make sure you get the people who are going to be interested and will adhere to the protocol. I think explaining, I think one thing that Lee brought up too is explaining to clinic staff what a deviation is. And because if you think about it from their viewpoint, within the standard of clinical care, yeah, sometimes you miss a blood draw and you'll just get it later, or I'm trying to think of things that are normal, or you
just timing of an EKG or
timing of an EKG. That in general for them, the assessment just has to be done that day. It's just a clinical care. But for research, we have a lot of things more programmed, and when it doesn't fall into that scheduled event, the timeline that we're required to adhere to, it's a deviation. It's a hard concept unless you're in research and understand the principles of rigorous, timelines and systematic collection of data. So again, figuring out, and that's why I kind of go back to trying to come up with a module that we could take around campus and sort of explain. Because that is probably a big thing that we need to try and explain to the clinic staff why we worry about something. That it isn't just an oh well, or the monitor. Again, there was a point where I did have somewhat of an inexperienced research nurse say to me when she missed some time points of some PK draws. She said, "Oh well, the monitor she'll just ding me. It'll be okay." Or the monitor hasn't caught it yet, so I'm not going to worry about it. When it's like, no, that's not the right attitude when it comes to research. You don't wait to be caught. Any other issues in building teams and working together with the clinic staff?
I think one of the issues with working with patients and clinical my area is to not only say it verbally, but to write down and speaking with the charge nurse or whoever is running the board. She's allowed me to write, if this is a possible clinical research patient, and they give me, time, especially if I'm over there talking with the patient, they come over and they're indicating one. So they'll give me a little time about and that works very well.
That's really a very good description of building a good relationship with the staff. Because you start with really you do want the charge nurse or the person in charge of the floor to be engaged as well, so that your presence is known and expected. And then it's the rest of the staff you have to, again, somehow sharing with them what you're doing and making sure they're part of it. That's very good. Anyone have anything else they'd like to share? I think there are, again, always resources that are available to help if you're having challenges with your clinic staff, or we don't always have the answers, but we're available to talk. We're available to brainstorm. I think everything we do, and we all do what we do in isolation so much of the time, but to have our colleagues call and say, how do I deal with this problem, can make a real difference. Can really give you additional information that you wouldn't have come up with yourself. So I think that was all I had for the presentation. If anybody wants to sit around and talk a little more, that would be fine, but otherwise I think we'll kind of end it here. Well, thank you all for sharing everything you did. It's an important aspect of research. Thank you. Yes, okay, good. I like hearing that because I was thinking, I think I put that in an email. So I like to say, because I was going to ask you, and I did. You did. I just thought it was easier than.
Oh, sure, I agree.
Yeah. Thanks, Lisa. You can go on the table. No, I was thinking, did the garage. I think not, we've already been checked out, but you're on the right track, absolutely.